Welcome, everyone, to the podcast where we dive deep into all things pregnancy, maternity, and beyond. And today we're going to talk about a very interesting topic about inductions. And I think a lot of parents get very anxious when they think they have to get induced or it is something that needs to get done. Today we have again Dr. Agha, our obstetrician and gynecologist, and of course our doula, Caridad, and our space holder. So, Dr. Agha, if I can ask you the first question, what factors would you consider when you recommend an induction?
Great. Thank you to have us again today, and it's a pleasure always to be together.
Thank you, Doctor.
So, it's a big question and a big answer. When we say that this woman needs induction, so first we need to decide that the decision itself that we need induction for this pregnancy.
Yeah.
Why is that? For different reasons. Either we feel the pregnancy is going too long, and she's not starting labor, or the baby is at risk, or the mother is at risk, or for other reasons like social convenience, or to make the labor under control in a way, then it means that we need induction for this pregnancy. So first of all is the decision by itself that we need the induction. Second thing we need to assess is when we are going to do that.
Okay.
According to the reason we go for the induction, we decide the timing. If it's just for the matter of late or prolonged pregnancy, we can go for 41 weeks or more.
Okay.
If it's for medical conditions, it can be 39, 40 weeks. If it's for baby's safety, it can be 37 weeks or 34. For more severe conditions, it can be 32, 34 weeks. For twins, it can be different age. And for convenience, it can be flexible. So the timing is important. And the other thing is that until we get to that age, what should we do to monitor the baby, especially if we talk about medical conditions? Yes, we set it at, let's say, 40 weeks.
Yeah.
But now we are at 30 weeks. Now, from 30 to 40 weeks, what are we going to do? How we are going to monitor this pregnancy? And if we need to change our plan for any reason, either to bring it forward or to cancel it or change it to cesarean section or whatever, then we need to keep this in our mind. The other thing is of course, when we decide the induction, it means that we are talking to the woman about it.
Yeah.
And we say that you need an induction, this is the reason why, and we are going to do it at this age, and this is the process.
Yeah.
So explanation and information to the mother and getting her consent for this thing, that's the other thing we need to consider. Then when we come to the induction, we need to physically assess the woman. Again, we confirm the age of the pregnancy, and we examine her, make sure the baby's head is coming down. We examine her from below to see the condition of the cervix, if it's ripening, if it's opened, and how far we are, so that will tell us what kind of induction we can, or the things that we are going to use for that. And then, of course, we assess the rest of the medical condition, medical background, and other issues for the woman to make sure the medication we are using and the entire process will be safe for her. And then the place where we are going to do it, is it the right place for induction? This facility is able to go or to do emergency cesarean section if we need to, or we can monitor the baby safely, and we cover all these aspects. So all these things we take in consideration when we make this decision.
And Doctor, what do you have that you can do? I mean, say a woman needs to go for an induction. What kind of medication would you use, for instance?
So there are different ways, and if we go to different hospitals, different countries, each one has their own kind of protocol for the things that they use, and they combine them in different ways. So in for simplicity, we are going to divide it into like mechanical ways.
Yeah.
Things like the simplest thing, we can even do it in the clinic, and this is not considered like official, but it can help with starting labor. Is what we call sweeping the cervix.
Yeah.
That can help to initiate something. We have breaking the waters if the cervix is open, and that can release some substances which helps with increasing the contractions. And we have special catheters. We can inserted through the cervix.
Okay.
And this will help the cervix to open up and ripen. We use it in certain situations. These are the mechanical ways.
Yeah.
And it's considered in some way safer than the medical or pharmaceutical ways.
Okay.
Because there's no medicine, it's not going to increase the intensity of contraction to an alarming level. The other side is the pharmaceutical, the medicines. We either use vaginal, either pessaries or gel, which is a kind of prostaglandin. Again, that helps to initiate the contractions. We have, in some places, especially in US, they use special pills. The misoprostol, at very low dose, they can use it. Here we don't do that. And then we have the oxytocin drip, the hormone, which is the main thing that can take the labor or the induction for longer, let's say, distance. That will create and maintain and strengthen the contractions of uterus, and that will make or bring the progress that we need to have. So these are basically the most popular or common methods we use for induction. In other places, they use other things like other pills or other medication, but either they are not evidence-based or they are very not popular or very local to that area they use. But broadly speaking, these are the main things that we use.
Okay. And for yourself, doctor, does it depend on patient to patient that you decide which one you're going to use, or is it a case-to-case basically?
Yeah, so all these things that we mentioned in the first question, we make us decide. So first of all, the examination we do. Is that woman or that uterus has started to do something? Is the cervix is ripened to some extent or not? That will make us decide. Now, is that woman in that first pregnancy or she delivered before? That make us change the plan as well. Did she have a cesarean section in the past? And we are talking now about VBAC, induction of labor in a VBAC. That will make us choose the mechanical ways, because that will be safer for her and for her scar. However, we can still use the pharmaceutical ways, but with more caution.
Yeah.
All right. Mainly, if we can prefer or we can incline towards the mechanical, that will be safer. Again, the size of the baby, the response of the mother to certain medications, her background, her allergic reactions, if she has any allergic reaction to any medication, all these things we can put in our mind when we decide.
Yeah. Okay. And Caridad.
Hello. Hi.
So we have a parent that decide or had a consultation with Dr. Agha and they need to go, for induction. What is your role? How do you support the couple emotionally?
So, well, it depends why they're going for the induction and why the recommendation was there. So obviously, if it's because of baby's health, then there's probably going to be a different conversation around that. Or if it's maternal health, there's going to be a conversation around that. My job is to assure them with confidence, and we do that with the information. So let's go over the information that he's giving you. Do you have any questions? Because usually when they're in the room, they'll listen to him, but then they walk out and it's like, what did he say again? Right? Because in that moment, it's a bit of a shock, especially if that's a conversation that, came from, it's a new piece of information. So we'll go over the information again. If they still have concerns, we'll get back to him and say, can you reassure them with this question and that question? So there's the information part. So we build the confidence around it. We assure them that it's a decision for them, but also, how do you feel about it? Did you question it? Did you ask, can we wait a couple more days? What's the priority? Like, is it necessary in this moment? Okay, so they get the information, they go back, they have another conversation, because he's pretty good about having a couple conversations if needed also. And if it's because of maternal reasons, then usually she has a conversation. We discuss what the induction process may look like. And sometimes she decides, no, I don't want to do that. Maybe I just want to go for the C-section. So then we go back and have a conversation with him. So then maybe they just want to skip the induction altogether. Because some moms don't want to sit there 2, potentially 3 days. I think we just had that. We just had that last week where she said, you know what? We had a conversation. I had a conversation with Cami. I really don't want to do this. I want to go straight for the C-section. And that's a valid reason.
Yeah.
Because, she knew she knew what that looked like already. She had had a previous C-section and she was comfortable with that. So that's okay. So that's where I would support them. And I was there with them that morning of. The other thing is just preparing the dad. because usually they don't understand that an induction process can be long.
Yeah.
Okay, I think you've had inductions for up to 4 days.
Mhm.
So when we say
Wow.
4 days, we mean
Yeah,
4 days, where it's really a key of you having patience, but also continue to have trust and faith in yourself that you can continue. Okay, so it's very difficult. So it just depends on why. Did they understand the information? Are they ready? Are they ready to sit there for potentially a longer period of time? Are they emotionally ready, but also mentally? And sometimes we've had moms that need an induction for mental reasons, right? So they're on medication that they needed to stop throughout pregnancy. So they needed to get the induction at 36, 37 weeks for her own sanity.
Yeah.
So there's so many reasons and so many ways that I can support them. Obviously, I'm there with them throughout the induction. So if it takes 3-4 days, I'm usually there. I camp out so that I can remind them to stay patient.
Yeah. But how does that look like? I mean, if the induction process starts in the hospital, right? Most of the time. Will they then stay in the hospital, say if it's 2 or 3
So I think usually if they introduce anything to the mom as a patient, they need to stay.
There is in certain places we call it outpatient induction.
Okay.
But this is very selective thing for certain patients, depends on the level of their risk and how far they are from hospital, and depends on the protocol of that hospital. There are many things you need to prepare and plan before you offer it. But yes, some people, they can start the induction, they allow them to go home and then come back when the contraction becomes stronger and things. But usually in most of places, like in ours now, once we start the induction, the patient is staying in until we have the baby out.
Yeah, okay. Yeah, because it's also probably for safety reasons,
Yeah.
right? So what can you recommend for families? How can they advocate for themselves? What they can do or their preference during the induction process? Is there any preferences?
Yes, so one step back, one of the things that we consider and when we talk about the patient is when we offer the induction, we have to offer alternative options to it. Is the induction is the only option we have for this pregnancy, or do we have alternative? Like, for example, they say, no, thank you so much, we'll go for cesarean section. Or no, thank you so much, you want me to go for induction at 37, but I want to take it to 40 weeks.
Yeah.
All right. So that's fine. We can find a plan to support your choice, but we need to understand the risks and benefits in each option. So discussing the alternatives and the management or the plans for each option, that's one of the talk we need to have with the patients or the couple. Now, how to prepare them, how they advocate for themselves. I always say it is education. They have to have their own, or to do their own research or homework. It's not like they come to the clinic and we'll tell them everything about the maternity care and obstetric problems and all these things. Yes, we'll answer their questions, but that should be based on some knowledge they gain. So they need to go, they read either from online sources, patient information leaflets, classes, people with experience or knowledge. I carefully, cautiously online or things. If they go to kind of reliable scientific bodies or websites, that's fine, but not everyone who may say anything about anything. So they get this information, they get the basis, and they will come. And then we can refine this information. We can correct, we can answer more, clarify, change, whatever. And then whatever we offer them the induction, they know about it, it will be easier for them to understand why we need it and what are the alternatives, what is the management, and everything around it. It will be easier for them if they have some background or some basis of information. So that's the best way for them so that it will be easier for them to ask questions. So they will know what kind of questions they need to ask.
Of course.
And that will be easier for them. Yeah.
Caridad, what would you suggest that parents do to advocate for themselves?
To advocate for themselves, well, it depends. What are they advocating for? We see a lot where people have been told that their body can do everything naturally, hands off. Nobody needs to check on me. Nobody needs to do anything. I can do it on my own. But then what we see a lot, especially here in Dubai, and we had this conversation earlier, is a lot of people need the help to get pregnant. And I feel like And the same token, if they accepted the help to get pregnant, maybe sometimes they need to accept the help to deliver the baby as well. And I think they kind of go hand in hand. Yes, we've seen amazing moms, for example, that have IVF go into spontaneous labor and have their baby, but that's not the case for everybody. Okay. So it's tricky. So why are they advocating for themselves? Is it based on evidence or is it based on information that they received online from an unreliable source? Okay. So I'm all for advocacy within evidence-based information. Okay. So they're advocating for themselves for good reasons. For example, my doctor is going on holiday next week. They want to induce today. Then that's a moment that 100% I'm like, well, did you ask the questions? Did you advocate for yourself in that space? And we're like, maybe I want to wait. Maybe I want to switch doctors. Or do you have somebody else?
Yeah.
And we've gone through that recently where she's like, you're going to deliver tomorrow. I need to go on holiday. I don't have time to sit around and wait for your baby. So she switched, and that's okay. So it just depends what you're advocating for. If you're in the hospital setting and then the doctor and you had a plan before and then they want to switch that plan, that's also another reason for you maybe to, speak up and talk to somebody, maybe ask for a manager, maybe sign an AMA. Do you want to discuss what an AMA is? It's basically an against medical advice. Thank you for the information. I don't want that. I'll take responsibility for it. But saying that, they also need to know that they're responsible for any outcomes and they should take responsibility for that. So I don't know. It's really hard to say because advocacy, especially in the UAE, is a different word, I think, than anywhere else in the world.
Yeah.
Right. It's very tricky. Even doulas in the rest of the world were trained to advocate for moms. Here, that looks different. That looks like a conversation with dad. And then dad, you speak up and talk to the medical team. So it's such a tricky word, especially here in the UAE. So parents, the advocacy is basically know that what you're saying is true.
Yeah.
Know that you have the evidence to back it up.
Yeah.
Know that it came from a good source. And then 100% speak up for it. Fight for what you believe in. Switch doctors if you must. Switch hospitals. We've known women to leave hospitals halfway through labor and switch hospitals. And be confident in yourself enough to do that. Okay, but for the right reasons. So, yeah. But if you find somebody that you trust and is giving you the information, I think also learn to listen a little bit sometimes. You need to learn to accept the help sometimes.
Is there any correlation between the amount of, induced births, normal births, C-sections? Is there any correlation that you see that after you, for instance, had an induction that there's more C-sections?
Not really. So it depends on many factors. So the most important critical thing is when we are inducing this labor, and if the woman has started something in early labor, that will make it easier possibly. So the most important thing is the age of pregnancy. So they found when we do it 39 weeks and beyond, that can reduce the chances of cesarean section. Or at least it can be equivalent to spontaneous labor, all right, or can be less. Up to 41 weeks, that's why what possibly nowadays in different guidelines, this is the recommended, let's say, maximum time to let the pregnancy go and advise for induction if we go. Because after that, after 41 weeks, they found the chances of cesarean section will be higher, and the possibility of the baby to go to the NICU unit after delivery can be higher. So by 41, you may be able to reduce the chances of cesarean section or keep it the same. After 41, because of the different reasons, the chance of cesarean section can go higher up. Not because of induction itself, but because of labor in general. So even if it goes into natural labor, it can end up with a cesarean section more likely.
Okay.
All right. Yeah.
Another question, doctor, because I can remember in I think it was the second child, I was already 2 centimeters dilated when they did the induction. Does that help? If you're already busy dilating? Because I think when you start dilating, it can take some time, right? It can take a week or...
Yes. So if we come to the natural labor, especially the first labor, or even anyone, this early stages or early phase of labor is difficult to time or to limit. So we don't know when it started. Okay. The woman, you may not have been feeling any tightening, or it was just a little bit, but the changes have started. Okay, the process has started. And only after a few days, when the contraction becomes stronger, you will come to the hospital, you will be checked, and then somebody will tell you, oh, you are 3-4 centimeters. Now, for how long you have been starting this thing, we are not exactly sure. It can be a few days, it can be a week, or it can be more than that. Now, so the trick here is that it can take long time. Now, when it comes to induction, we can't offer, practically speaking, we can't offer a week to keep the patient in hospital because we want to mimic exactly the nature. All right. So, and that's one of the possibly downsides of induction. It's not giving exactly the same time, natural time of labor. It will be a bit quicker than that. And the first stage of that latent phase, it can be tricky. It may not progress from there. So if you reach to hospital or reach to the induction and you are already 3 or 4 centimeter, yes, of course, that means that you pass a good stage, and that will make it possibly easier for you to progress from there. And so yes, if you progress a little bit more and you don't come like genuinely from 0, that will be possibly better. In our examination, it's a bit technical. When we examine from below, we check the cervix, we have something called Bishop score. It's like different things, we add them, like each one has a different score, and we sum up them, and we get a final score. So when this is 6, 7, that's a good level. It means that we have a good chance for success, and we can build on that. But that doesn't mean we cannot start earlier, but it means that we are at a good level now.
Okay.
Yeah.
I think a good question I asked you earlier too was if a mom goes into the hospital and starts an induction process and doesn't get past 2-3 centimeters, and doesn't want to continue, doesn't want to speed things up, doesn't want to maybe potentially be there longer, can she go home? And I think that's usually depends on the doctor. Maybe like, okay, doctor, I need to go home, I need to reset, and then come back and try again another time.
So is that a possibility?
Yeah. So again, the trick part of the induction, as we said, that we had 3-4 days, but still we won't be able to be like nature exactly. So the trick part is the timing or the length of induction.
Yeah.
The more we can give, we will end up with a result at the end, providing everybody is safe and doing fine. The mother, the baby, and everything is okay, because there will be kind of element of cumulative effect of whatever we do that will be showing itself later on.
Yeah.
So if we are not in urgency of delivery, if we are not desperate to have the baby out because of any medical condition or any risk or whatever, yes, we can prolong this induction as convenient and as practical as it could be. So we don't need to rush it to finish it in 24 hours or 48 hours. If one cycle of induction or after 24 hours it doesn't work, and we make sure the baby is safe and the mother is safe, yes, we may allow them to go home and then come back later. But this is not very common in practice because still many people, they feel worried because of that cumulative effect of medication we already gave. It can show themselves later on. So they don't feel safe that once we start induction, I'll let you go home and come back after a week or something.
Yeah.
But still, in some places they do that. It's not invalid.
Or it's something like expected management where they come to see you in the clinic every day, maybe, or something. That can always be a negotiation, right?
Yeah. So always we can find a way. And again, if we agree on plan, we need to agree on how we proceed with this plan. What's the dynamics or the elements of this plan? How we are going to action it. All right, so we tell her that, okay, you'll go home, but I want you to come back, let's say next day to me to assess the baby again and make sure. And I want you to come back if you don't feel well or you feel pain or you feel whatever. So we need to have a kind of conditions so that we achieve the plan or that choice for the woman. So yes, it's possible, providing we meet certain criteria and the woman needs to, agree or I don't want to say comply, but to be happy to do whatever we feel is necessary for her.
Okay.
All right.
So there needs to be a lot of trust.
Yes, of course. Yeah.
Doctor, you mentioned something and help me understand that with the things that you can do, there will be, it can show later. You use those words.
Yeah, because if we use pharmaceutical things, medical or medicines, this will be absorbed into the body. So this can remain in the body for some time, the half-life of the medication. So it can stay for 24 hours or more. And if we add more, let's say, because we don't put this medication once. So for example, we have a gel, we can apply it 3 times after a certain number of hours. So by the end of 24 hours or 48 hours, there will be some level of this medication in the body, and this can work later.
Yeah.
Not necessarily immediately, but later can show themselves. And then we will have contractions getting stronger and stronger.
Yeah.
So that's the other thing.
Okay.
So that's why if we want to, let's say, cancel the induction, at least we need to have a break or we need to repeat the cycle. We need to have a break of sometime, possibly sometimes 24 hours. We give a break and then we start again.
Oh, I see.
Because if we keep giving medication one after the other, then we may end up with hypersensitivity of the uterus and hyper or loss of contractions at the end.
Okay.
So we need to be careful with it, slow, and give gaps in between, and that will keep things safe.
Okay. Yeah. Is there any specific misconceptions that any of you can come up with? That
So many. So many. No, but everybody always says if I get induced, I will end up in a CS, or if I start with one interventions, I'm going to have them all.
Yeah.
So they
Special
call it-
epidural.
so they call it the cascade of interventions. If I go in for an induction, I will have to get the epidural. I will need the fluids. I will need the Synthone. I want to end up either in a vacuum, instrumental, or C-section.
Yeah.
Like that's the big myth, right? The cascade of interventions is a huge one. And I'm like, it depends, right? So like if you go in and as soon as those first contractions start, you ask for an epidural, but that happens with spontaneous labor also. It's not only with induction. Then yes, the loss of movement, you might need more chances of getting the hydration, right? The fluids. So it's the movement thing for me. So if you lose your movement, you lose your body autonomy, your freedom to, have that extra buoyancy, for example, like if you can't use the water, because we've had a lot of inductions, I still end up in water births, and they've been successful as far as that goes. And it's because they were able to still use all the pain relief and the comfort measures, and they still did the homework beforehand, and they found somebody as patients, as Dr. Agha, where they don't try to speed up the process. So they try to, so yes, induction can still look natural in a way. So it just depends. Like you need to understand how to navigate birth.
Yeah.
And that takes a lot of learning beforehand, which is why we do those workshops, right? And we do the classes, and the hospitals offer the antenatal classes, and you can have the conversations with your doctor. But that goes with spontaneous or induction. So it goes with both ways. Once that first intervention is given, the next intervention is necessary if it's necessary, but usually if you do things for yourself and are able to move around and you can sustain, you have your pain management tools, that can decrease the chances of that next intervention needing to happen. So it's really about the homework that you do. But that's with everything.
Can both of you give me an example of where you had an induction? So basically a success story, and how both of you worked in synergy together.
So one of our favorite ones, and she's hilarious. She was coming for us for a second time baby, and she was driving in from another Emirates.
Yeah.
So she was coming from Abu Dhabi, for example. Yeah. So it takes 90 minutes to get here from her home. And her husband was terrified of the baby being born in the car, for example, going into spontaneous labor. So they moved in to a hotel 3 minutes from the hospital for a week. They brought the dog, they brought the nanny, they brought their toddler.
Yeah.
And about day 6, you could tell they were like, we're done. Like, we don't want to do this anymore. And they're like, what are my options? And then he's like, okay, well, let's discuss an induction. This was going to, obviously 100% out of convenience for them. But for them, it was necessary for the marriage to continue, one. For her mental sanity. And he did. We went upstairs. He started the induction process. And I think not even 6 hours later, her baby was born in the water.
Oh, wow. 6 hours?
6 hours, because she was a second-time mom. Her cervix was already, good bishop score or whatever it is. Medical terms that I don't use. But it was success.
Yeah.
And everybody was happy. And we laughed and we danced. And she moved around and she used the breathing and the movements, and she had a water baby, and everybody was happy with that. So yeah, I think it can be fun, and it can be used in situations like that as well.
Yeah.
I think that was one of our favorites.
Yeah. On the other side, yes, we have the very time-consuming or long kind of inductions, especially when. So not only me, so all doctors, when they come in and examine, from the experience you have and whatever, you feel, okay, that doesn't look promising. I'm not going to end up really successful. That's something you talk to yourself inside. You're not necessarily you are going to share it with the mom. Although some doctors, unfortunately, they do, and they make it a reason to go for a cesarean section. Oh, it doesn't look you're going to have a vagina, there is always low. So, but inside yourself, okay, I'm not really happy with this, but we'll start, we'll go on, and then after 24, 48 hours, the nurse will come in, or the junior doctor will say, oh, she's trying to push, and she's fully dilated. So amazing. So these are amazing things, amazing for her. It's so surprising that she achieved it after all this time. It's still, for us, even after all these years, it's still surprising. Wow, I mean, I wasn't really impressed with the examination in the beginning. Now she made it, and she's in. When we see the head of the baby is really high, we feel, oh, it's not going to come down. But then we see it's happening. So it's all good news for everybody. So these things. And we had a few inductions for VBACs. And again, we took 1 or 2 days, and even we used the drip of the hormone, which can be risky or alarming thing, but we did it. So yes, I think the trick thing is to be patient with the induction, to give it time, as practical again as you could, and as convenient for the family as well.
Yeah. Doctor, how is it different to do an induction after VBAC?
So with the VBAC, what's the difference between the induction for women with no cesarean section in the past and one who had the cesarean section in her background? So the uterus in the second one will have a scar because of the cesarean section, and this scar is the weak point or weak tissue in the wall of the uterus. Now, the wall of the uterus is made of muscle, and that's why it's accommodating the pregnancy, and that's why it's contracting to get all the strength. Now, the strength of these contractions is too high, right? And it will be pulling up the cervix. Now, when there will be tension on this weak point, it can open up. And that's the main risk. That's what we call it dehiscence or rupture or opening the scar. And it's quite an alarming emergency for us. And it can be really serious. And you only need, or you have few minutes to save the baby or the mother. Otherwise, you may lose the baby. So this is the risk, basically, is that this scar can open up because of the contraction. So you need to be careful with the frequency and strength of the contractions you are trying to create in the induction process. So we need to be careful with the medications we are using, the level of the syntocinon or that hormone we can go with, how far we can go with the contractions so we don't exceed certain limits. Again, we try to use the mechanical ways rather than the medicines. That will make it safer. So these are basically the main things.
So it's also probably more monitoring.
Yes, exactly. And continuous monitoring for the baby and the mother, make sure, because we have a list of things that will tell us there is a dehiscence or opening up the scar and we need to run for a cesarean section or not.
Yeah. I mean, this is, if you sit with parents and they didn't think that this is something that they want to do in induction, they can be quite anxious with this decision. Right. Any advice that you have for parents when they are faced with something like this?
So the biggest reason I see for an induction is, for example, something like her water's ruptured. And now it's been almost a full day since her water's ruptured and no contractions have happened. So in their mind, they were going to continue. The labor was going to progress naturally. She was going to be able to go in. And then all of a sudden, the doctor's like, well, your chances of infection are now increasing.
Yeah.
I think we should go for the induction. And obviously, there's always a little bit of that shock, that fight back for a little bit. He does negotiate a little bit. Okay, just come in overnight, start the antibiotic. Let's see where that goes. And in the morning, if nothing has happened, then we'll start an induction process. So during that time, I'll sit there. Sometimes we play cards. We'll watch TV. You walked in on a funny show the other day. We were watching Eurovision on Netflix. Just something to make them feel at home. So I always say, bring stuff from the house that's going to make you feel at home. So you don't feel like you're in an external hospital kind of setting. So once they feel like they're at home and they feel safe, I think they start to accept the possibility that this may work for them. And once that mental shift happens, I think then they can allow the process to work for them. Because sometimes they do have that wall, and then I feel like whatever gets done for them, it's not going to work.
Yeah.
So they need to bring down that wall. So getting to that point is very important. And I don't think you're ever going to force somebody to get induced unless they were 100% ready for it and they accepted it. So yeah, I think it's just that mental preparation of feeling safe, feeling like that it's gonna work for them, and then usually it does. I don't feel like it rarely fails. I feel like there's success. I think as long as mom goes home with the baby and they're both happy, that's always a success.
100%.
Because we've even had VBAC attempts where they still end up in a C-section for whatever reason. And they're like, oh, I failed. I'm like, of course you didn't fail. You got home with a baby. That was the goal all along.
Yeah.
And the fact that you tried, and you always tell them the fact that you tried and you felt confident in yourself to try, that's a huge accomplishment.
Yeah. Yeah. And interesting, I'm hearing that you can even do induction and water birth.
Yes.
Can you tell me more about that?
Not everybody.
Not everybody.
Not all providers will allow.
Tell anybody about that. Don't tell anybody. Let's say that it's not.
So I think the only contraindication is if they're on the oxytocin drip. So if they're on the oxytocin drip, then they're technically don't go in the water. Okay. But everything else leading up to that. So like if he's do the propis or he does the gel and then the contractions pick up on their own 100%, just walks away and pretends.
Okay.
You can almost pretend that it was spontaneous labor and it just progressed naturally. So moms use it even in labor. Like while they're laboring, they get in the tub.
Yeah.
And that's one of the huge pain management techniques. So when a hospital tells a mom, and this happens a lot, and this is why the process of talking to a doula and talking to her team is so important. If I need an induction, the second you give me something, am I still allowed to move around? Am I still allowed to use the water? And if your doctor says no, because that's our policy, then maybe that's one of those considerations where like, can we negotiate it or do I need to change?
Yeah.
Because most people don't find out until the day of. And then it can be a shock for them. Well, you've taken away all my pain management tools. Now what do I do? Now I need to get the epidural and now I need to speed it up and I need to get the Cinto and then that cascade happens. So I think this is super important. We've had lots of inductions end up in the water because he doesn't take away that pain management tool, which is the water, which is so huge and important. And I know we'll have a whole episode on water at some point. But yeah, I think it's really special.
No, absolutely. I didn't even know that was
A possibility.
Yeah.
85% of places is not a possibility, but you can find some.
So the idea is that induction of labor is considered in obstetric world as high risk or risk factor for that labor. And any labor at high risk, then they need continuous monitoring of baby's heartbeats.
Okay.
And of course, monitoring the mom too. So that's why they don't advise, and they keep in mind that they may need to interfere immediately to save the mother or baby or whatever. That's why they feel the water may not be a safe spot for the mother to be if she is at a risk for certain things, and the team needs to come in immediately and do something immediate. So they feel safer when the mother is on the bed, so that we can deal with whatever we need to do.
Yeah.
All right, so that's the idea of it. But for monitoring, we have now the wireless machine that we just attach it to the tummy, and the machine is somewhere in the room,
Okay.
and the woman can stay in the thing. And if we have vigilant team and we are monitoring closely and we are looking at all different aspects, then we can cover all these things and we can get enough reassurance for us and for the couple.
Yeah, and that's key. He said vigilancy, but not just vigilant. And we're talking about confident. So it's staff members, midwives, nurses, or doctors that are able to feel confident enough in that space. So they're not bringing their fears, they're not jumping to conclusions. They're dealing with the facts of the moment.
Yeah.
So like a midwife that is not comfortable with water birth, or a nurse, period.
Yeah.
On a regular day with spontaneous labor, mom comes in at 8 centimeters, she's still freaking out. No, please don't use the water. I don't trust it. Then obviously that's not going to work for you. So having a confident team that trusts the process, that understands the process is just as important as you choosing, where you're going to birth and what kind of induction, when and how, and all that kind of information. So again, this is why we always say it's so important to get the information before you walk in. All this homework is done before. So induction, no induction, water, VBAC, whatever, you have to have the information. You need to understand your team. You need to understand not just your doctor, but the midwives, the nurses, everybody. That's why I call them the labor squad. My besties are the labor squad because we've it's a team that's confident enough to understand and work with the facts and be super present and super mindful.
Yeah, I mean, what I hear constantly by talking with you guys, it's definitely the teamwork. It's, you know, the obstetrician, it is also the doula, the nurses, the midwives, whoever is in that room to support the mom. So it's never a one-man show.
Yeah, of course.
It's alignment. Everybody needs to be aligned
Yeah.
with the same goal, with the same plan, but the same beliefs as well, and the same trust in the system and trust in each other and valuing each other. It's very important.
Yeah.
All tuned together.
Yeah.
Everybody together. The whole labor squad. Everybody comes in with their own cape.
So is there any advice that you can give for the dads? How can they support their partner who's going through this induction process?
I always say, find the solutions before you walk into the room. So understand what the solutions can be. For any dad, any kind of birth, I always say, don't ask questions to the mom. Yes, to the team outside, to your doula, but offer solutions the entire time, okay? Don't bring fears to the space. How long is this going to take? Why is this taking so long? This doesn't seem normal. Does this seem normal to you? And then, like, moms are so vulnerable in that space and they're sponges. So when somebody comes in and says, that seems painful. Is it painful? That seems like a lot of pain. All of a sudden, she wasn't thinking of pain and she's like, yeah, I think so. Hold on. Let me see. Oh my God, it's the worst.
Yeah.
Because they're so vulnerable. So dads need to understand this about the mom's mind at birth itself. Okay. So be confident. If you're going to have a moment where you need to check yourself, go check yourself. Go step outside. Go get the coffee, go for a walk, do what you need to do to check yourself, but then don't bring it into the space. And then come back in with a space where you're just holding complete and you know, just a powerful space. Is supporting her, is holding her, is smiling when things get a little, you know, scary, and not to judge her when she says something. And we always joke, what happens in Vegas stays in Vegas. I'm like, what happens in the birth room stays in the birth room. And yeah, so just be very supportive, be empathetic, know that you're probably the one with the biggest bond with her. So she's going to look at you the entire time. If there's fear in your face, she's going to absorb it. If there's distrust, she's going to feel distrustful as well. So just come to a place of peace, bring the peace. If you need, usually the dads hire me, I think, more for themselves than for the moms.
Yeah.
And they always say, you're here for me.
Yeah.
So just make sure you keep me centered so that I can be good for her. And that's usually the negotiation I have with them. I'm like, yes, I'm here for you. Having
said that, I mean, but still the dad will be the extra ear and extra eye for the mother because of the mental status of the mother when she, starting from the antenatal care and visits to the clinic until delivery and things. She has her own anxieties and worries and everything, so she won't be that aware or alert to everything around her, and especially when it comes to consultations and then going to the hospital and things. So the dad, that will be the person who will grab this extra information and who will ask the extra questions that the mother can miss. And then he will be the one who might be explaining to the mother later on after they leave the clinic or give the support. And they will be alert to whatever is happening around that the mother can miss because she is not focusing on everything else. So yes, the dad, they have big role in that, but they need to do this role or that protective role in a cool way. So to keep the peace, but make sure that they are happy with everything and they feel protected, they feel safe, they feel dignified, respected, all these things. So part of this will be on the shoulders of the dad because the mother won't be able to focus on these aspects.
Yeah, because it's exactly what you said, Caridad, before, that you use a lot of times the dad to advocate for the mom, right? So there must happen a lot of discussions before the birth between mom and dad to understand what she really wants. And if something happens, who's going to take that decision at that moment?
Because one big trend that we see, and it's not a good trend, it's not a happy one, is doctors coming into spaces, ignoring the laboring mom and talking only to the father. And I had this conversation just recently with a midwife. She's like, yeah, this doctor and that doctor only speaks to the husband, never speaks to the mom. And this is part of your core message, which is that humanized birth, which is the mom being 100% an active participant and understanding her role and getting to decide for herself. Okay. So yes, I mean, it's important for the dad to step up, but it's more important for that the woman is understood and, and acknowledged. But in that moment, yes, he's the biggest witness. He's the biggest supporter. He does speak not for her, but with her.
Yeah.
And because it's something that they decided together beforehand. And he's advocating for her and he's speaking up for her and he's answering questions, but then always looking at her and checking in with her to make sure that she understands what it is that they're discussing. So like ignoring her is huge. And then I've seen dads check the doctors and say, excuse me, let me ask her. Let's talk to her. Or like somebody will come and talk to me. I'm like, I'm the doula. Speak to her. She's the mom. Speak to her. Because I need her to know that what you offered her, she understood. And I need her to say yes.
Yeah.
I need her to understand what's going to happen to her and that she got to be an active participant.
So it's almost like the mom speaks through the dad, right?
Yeah.
So they need to be quite aligned. Is there sometimes that they're not aligned?
Mm-hmm. Sometimes. Sometimes we kick them out. We should be able to, but we don't. But sometimes.
Yeah.
But it's not just the dads, because sometimes they'll bring the whole family, and it's an older mom that believes we should do this. We should do this. Like, why are you fighting? Or the dads will come and say, why are you trying to be a hero? Just go straight for the CS or get the epidural. So they didn't have these. They weren't aligned before they walked into the room. And that alignment needs to happen before they walk into the room. Otherwise, it's not going to happen while it's at the birth. Because I've been there, where every time I went to their home, he was saying one thing, she was saying another, and they never got to that same point. And then the day of birth, it went his way. Because again, she's vulnerable, she's open, she's looking to him for strength.
Yeah.
And so this needs to happen beforehand. So I always tell the mom, if he's not aligned, then don't invite him. Don't invite him. He's not allowed in the space. Look for another support. Get a second doula. Bring your mom. It's fine.
But the other extreme of examples, the mother herself, she would ask to delegate all the decision power to the husband or to the dad. But as an advice, this is not acceptable from our point of view, because medical legally, whatever decision or consent we need to take, it should be from her. And should be a legal process, and certain people then when this attorney of power is given to someone else. So it's not like that easy to say, no, don't speak to the mother, or don't speak to me, speak to the husband, and the husband will take decisions for me. It doesn't work like that. We have to speak to you directly. We have to take the yes or no from you. Yes, you think with, or you discuss with your husband, or decide together. I have no problem with that. But the final word should come from you. The husband doesn't have the authority to take any decision on your behalf while you are awake and you are communicable and you can take the decisions yourself.
I mean, stuff like, when was your last menstrual period and when did the contraction start? If somebody keeps asking them those questions, but for like decision-making things, 100% the mom needs to be involved.
And what topics should families discuss with their healthcare provider in advance of doing an induction?
So basically, the first question is that why we need the induction. Well, so you are advising us to go for induction. Why? And is this the only option? Is there a different option for that? Can we wait for a longer time or not? What is the benefits and risks for each thing? So you are saying that we have to go for induction at 37 weeks. All right, so if we take it to 40 weeks, what are the risks? Can we do that? Can we wait to start labor naturally or not? Is that safe or not? So basically, it's discussing the different options, and because at the end, from our point of view, it's very, very rare to have white and black options. Most of the times is a matter of collective, let's say, factors. Collectively, I see the induction here is safer or better than waiting. All right. So it's a matter of balancing risk and benefit for each side. So it's a negotiation, it's a trade, it's a compromise at the end. And if we don't take this option and we are taking a different thing, then we need to do something differently. Although even if it's but with this, and that's what they need to understand sometimes. If, for example, if we say we will wait for longer time, yes, I can do that, but keep in mind, whatever the monitoring and things I'm going to do may not be that perfect. The risk is still there. There will be higher risk on the baby, but we can accommodate to some extent. But there's no 100% guarantee, for example. So that they need to understand too. So what they need to discuss is the option itself, alternatives, pros and cons for each one, and if they can go for alternative thing, and then they need to understand the process of induction. So they ask step by step what's going to happen. So we are going to come to the emergency department. You will be admitted. You will go to the room. They will do routine checks. And then the doctor will come and check you from below, and then we will check the vital signs, and then we'll give you the medication. And usually we go explain to them step by step, because the induction, as mentioned before that, we talked a bit, it's a stepwise management. It's not exactly the cascade of things. It's not like routinely I have to go through all the things all together. No, it's stepwise. I give something and then wait and see. The labor may go by itself natural and progress natural without any further intervention. And that's when we can allow the woman to go to water, for example. But if she doesn't progress, then I need to do this next step, until we get to the labor. So we need to explain to them these things, and they need to understand. Because the more you know and the more you feel it's familiar to you, there will be less surprises. And when you we both set the expectations, that will be, less surprises for them and less disappointment. Mm-hmm. And they will be happy at the end with whatever the outcome we will get out with, because they already knew about these possibilities. Yeah. So it's not a surprise when you say, okay, we have to stop here, we have to go for C-section. Yes, we told us about that, and we know that there's a chance of C-section, and we got it here. That's fine. We are happy to go with it. But if they don't know anything, everything we do, any gesture, any action will be a surprise. Oh, why are we doing that? Why are we doing that? It will be very difficult to explain at that time for everything we need to do. So the more we know about the process and indication and outcomes and possibilities, the better, and it will be easier for them when they come to hospital. Yeah.
For me, it's asking them also, do you have a time limit? Because that's different for a lot of medical providers. Some like even 6 hours from induction, you're not at active labor, then we're going straight for CS. Like that's something the doctor will tell you. Another doctor may say, we'll give you 24 hours. If nothing has happened, then we can wait another 24 hours and then maybe, reevaluate at that point and have another plan and discussion. So it has to feel right for you. And then you have to ask them about the time limit. And then also, can I use the water? And what kind of pain relief options do you have? What do you recommend? And some of them say as soon as you start and you're 3 centimeters, you're going to get the epidural. We're going to break your waters. We're going to start the Synto. Like that's their plan every induction. Yeah. That's just the way they do it. And they're not going to change it. If that feels fine for you, then 100% you still continue with them. And not, then you continue to ask questions as well.
Yeah. But I think it's very important.
Yeah. To understand.
It's very important to understand, because I think as a mom, at that point, if you didn't do the research and if you don't know that you have options, you're going to get to a situation where that option might be taken away from you without you even the knowledge. You don't even have the knowledge that you could have made a different decision.
Yeah, so you just show up for your show without being the star.
Yeah, exactly.
Your show has been planned out for you. Yeah.
And this is what we're all about, is that, Caridad, you say it beautifully, that the mom should be the star of her birth, right? Yeah. It's her birth. So, and I think that is why it's so important to have these discussions so that we can bring this information to the parents.
Thank you so much.
Thank you.
Thank you, Doctor.
Thank you, Dr. Agha.
Thank you so much.
Thank you, Del.
Thank you, Caridad, for being here. And then thank you once again for listening and tuning in. We are always here to inspire and educate, and remember, your birth matters. Thank you very much.